Please be seated.
Tonight,
Live from the Athens Shoulder Course Arena,
in Athens, Greece,
this is the mini battles face to face. In the red corner from Germany, he may be young, but he is indeed experienced. Directly from the Zentrum Leipzig, Felix, the Duke, Dyrna. In the yellow corner, the national champion of Greece, the professor of orthopedics, faculty of medicine at the University of Thessaly, and ESCA second vice president, the Iron Mike Hantes. In the green corner, the director of the 3rd Orthopedic Department at the VIA Hospital and the course chairman of the Athens Shoulder Course. The first half of Manos and Manos. This is Manos, the White Bomber, Antonogiannakis. Referee of this fight, he can be found whenever he wishes to be found at the Sports Trauma and Pain Institute in Thessaloniki, Greece, as well as the Medical Center in Wuppertal, Germany. This is Christos. Boom boom, Koukos.
Now? Okay, a bit better now. So I want a clear fight. Yeah, no, no hits under the belt. So I think we can start now. Watch it, I'm watching you guys. So let's start with our case. Okay, rotator cuff. There is a tear. Let's fix it right. Midi ball 3, come on, let's start. So, here we have a 54-year-old male. He's right-handed. What he does actually, sports activities, CrossFit, and he's a weightlifter. He has pain that started like a year ago, but he hasn't had any trauma. So the clinical picture, he has full active range of motion, painful range of motion though in abduction and flexion, forward flexion 50 to 180 degrees, and external rotation 120 to 90, no night pain. So what do we have here? Like no tenderness on the greater tuberosity, AC joint, no AC joint tenderness. The biceps is tenderness is positive. The test for supraspinatus positive and infraspinatus at the same time for impingement syndrome, and has a painful arc. A speed test is positive. O'Brien test is positive. Lift-off test, negative. Belly press test, negative. Bear hug test, negative. And no external rotation lag sign. So this is the patient. Oh, okay, weightlifter. Yeah. CrossFit as well, man. Yeah, that could be as well at the same time. Okay. There's a range of motion that we see. Guys, take a good look, because I'm going to ask you in a bit, yeah? Okay. Okay, this is the patient. And let's... it wasn't actually, like, do we know about the strength, Manos? Or?
Limited from pain. Just limited.
It says limited from pain. Can we see it again now? Like, because I think, I don't know if we missed it. Can we play it? Okay. So let's get the next one. No, one here. Let it play. Okay. Next one. It's not just try and fix it, try and find it. Okay. Have you all seen the MRIs? Okay. Who wants to start? What would you do here? What do you see and stuff? So, should I start with the young one?
Do I get the microphone?
You can get
I
that
can
one.
take that one. So for me, it's about his history, right? So he's lifting weights, and probably most of the time in front of his body and less of the time behind his body. So there might be a muscular disbalance, this pec. Probably also is a little stiff up front there, and that's why he has, pain. So for me, this is more or less like a biceps anterior cuff or AC joint problem. And you can see that in the pictures as well. So mainly it's the bursitis or all the liquid is in front of the shoulder. It's all an anterior problem. So that's at least what I see on the pictures and from what he presented in the video. And that would be the thing that I would address. So if he would be in my clinic, probably that would be a good case for first non-operative treatment. But since we're now battling it out, I guess I will fix the anterior edge of that supraspinatus with a single row anchor and also take care of that biceps.
You said an AC joint, but there's no tenderness on the AC joint, yeah?
I'm 100% positive there is, because now he just reduced his weightlifting due to the pain. And as soon as he will start, there will be edema on the lateral clavicle.
So actually, to be honest, I expected a different case, Manos. I prepared for a double row fixation, but this is definitely not the case for a double row fixation. So I will go against my belief, because I'm a fan of double row fixation, but definitely not in this case. So I'm sorry, Manos. But I would definitely agree with Felix. Most of his problems coming from his biceps inflammation. He may have a small partial tear of the supraspinatus, but I think if we go for operative treatment, I would address his biceps mostly.
So the case is, what would you do in a patient that it is very active, very well trained, muscular person, does a lot of active
We're talking
exercise.
about that guy that we saw, with a
this one,
sportsman.
and has pain for a year. And he tried the injections, he tried reducing the activity, he tried any kind of physiotherapy, and still there saying that I have pain.
So the first comment is if we go for surgical treatment or if we continue with conservative treatment. Since he has pain 1 year, I would most probably go for operative treatment. I suppose that most of the audience agree on that. Yes or no? No? I would not. Who is going for conservative treatment?
Who actually thinks it's just a partial lesion that you don't really have to address, and it's just the biceps. Even though you see actually it's just on the sagittal on something small.
Do you have a plain X-ray of the shoulder?
No, it's not included.
Second, if you read the MRI, you see that he's got a good spur of that problem as well.
Yeah, he has some osteophytes,
Yeah.
correct?
So if you do it, I would probably, again, if you had the conservative, it's okay, but otherwise I'll start with conservative, and if not, I'll go for surgical to do a decompression.
Just a decompression, nothing else.
There's a tear, I'm already there.
Can I have the microphone? Yeah, of course. So if there's no structural damage, right? I mean, there's nothing to repair. And this guy wants to do heavy lifting, and as soon as you touch his cuff and you overtension it because there is no tear, he will have more pain. And for me, this is not a good case if he wants to go back. Especially CrossFit athletes want to be overhead athletes, so they want to lift it up. And if you touch that anterior cuff, he will have pain in my hands, so I wouldn't do it. But when we talk about reconstruction...
What about biceps?
So the biceps is a case where I would do it. So if he really points it with his finger and tells me this is the only thing that is bothering me, that's the one that I will take care of.
Yeah.
Even if I see an anterior cuff tear intraoperatively, I would not address it.
The problem again is that this patient is complaining because he has all the supraspinatus tests positive, and also in the MRI you can't see something so tremendous. The activity level is that producing symptoms, and the symptoms are mainly from the cuff. It's not mainly from the biceps and the cuff, not the AC joint.
Yeah, but you cannot be so sure that the cuff, this small partial tear, produces so much pain. I mean, I'm 100% convinced that his pain comes from the biceps, and what you have to address is the biceps.
The problem is,
even with a single row or a double row.
that if you get this guy to the operating theater, and he's 55 years old, and he wants to come back to his sports, and he's trying everything till now for a year, and you know that there is something there to the supraspinatus that is symptomatic, you are going to leave it as it is and do only the biceps? Because this is the question. The question is practical.
Did you operate him or not?
You get him to the operating theater.
Did you operate him or not?
Yes.
But
this is...
So let me ask you one more question.
Arthroscopic view?
Oh, excuse me?
Can we have the arthroscopic view? I mean, this is a decision about the supraspinatus based on the arthroscopic view.
Yes.
But most probably, I would address just the biceps and do a subacromial decompression.
So what do you tell him when you do the surgery? How long will it take him to get back?
Depends on what you are going to do, but you must expect something like 4 months.
So you want to go back, you want to fix his cuff. So what do you think, how long he has to pause from CrossFit or weightlifting?
After fixing the cuff.
After fixing the cuff.
Yeah.
It's going to be something quite similar. I mean, you have to reduce the activity for an amount of time in order either to heal by itself or to do something to increase the possibility of healing. This is the question. I mean,
so if I would fix his cuff, I would not let him weightlift for 6 months. If I fix his cuff, he would not be doing CrossFit, overhead weights for 6 months.
Yeah, I was
If I just address his biceps tendon,
wait.
it's probably 6 to 8 weeks.
Wait. If you have a weightlifter and you make a tenodesis of the biceps, you believe that you are going to send him back early, or you are going to see a Popeye deformity and this is going to come back and say to you, what have you done to me, doctor?
We're not talking about biceps tenodesis.
What are you
We're not about biceps tenotomy, but biceps
we are
tenodesis.
talking about a practical issue. You have a patient, you have him in the operating theater, and he's this type of guy, and you have to say, what I'm going to do now? I'm going to do only the biceps, I'm going to do an AC, a distal clavic excision, I'm going to do acromioplasty, I'm going to do a repair of the calf. What
So let's take the opinion of the audience.
Don't fight under the belt first, yeah? But let's take the opinion. Andre.
So, to simplify the situation, you can perform an ultrasound, a dynamic ultrasound in consultation, and you can see the dynamic of the biceps. You see the biceps slipping medially or posteriorly, conflicting with the supraspinatus or with the biceps. You can do the tests of the supraspinatus with the ultrasound on top, and you can see that's a trouble there, and you can explain to the patient, look, your biceps subluxates in that direction or that direction.
Pulley lesion, yeah.
This is my indication.
No doubt about
a pulley, type 2, like where is Frank?
But you convince the guy and you say, we're going to treat your biceps, and during arthroscopy, if we find something else on the supraspinatus, of course we're going to...
Yes. Who actually thinks it's more the biceps here, and like you don't really find transmural tear here? Yeah. And I think it's because of the pulley lesion, type 2, like from Frank's classification.
Practically what I see, most of the patients that have a tendonitis that is not healing and a tendonitis that is producing symptoms, and symptoms, it's a problem of the biceps tendon and the anterior part of the calf where the biceps flex.
And the question again is, if it's a partial tear, if it's a partial tear, not a transmural one, would you actually fix it? That's what Felix actually said. Would you fix it if it's a partial one? No. Huh. Okay. Oh, yes. Okay.
Do you expect in this patient a lesion in his footprint more than 25%?
Actually, no.
Yeah. So I will not fix it.
And so we do know there are specific sports that actually produces partial tears just by their sport that they do in. We know that especially like for swimmers. So they all get, after 15 or 20 years of high-level athletes, they get articular-sided 20-25% tears just because of the kinking of the supraspinatus tendon on the interior margin. Yeah. So, and if you fix those, they will never be back swimming. Yes. But and this is the same for me, for the weightlifters. If you make them anteriorly too tight, and that's what happens if you do biceps and cuff and maybe even the interval closure just because it looks nicer, that's not a good indication for me.
Yeah.
So finally, what
the problem with this patient is that the tear is near the anterior border of the supraspinatus. These tears that are usually asymptomatic are a little more and they leave the anterior border alone. Now, what we did at the end.
There is a question.
There's a question there. That's a good question.
It's much more important the location of the tear than the full or partial thickness of a small tear. Small tears are very well compensated, either partial or full of the supraspinatus. The problem most of the times when they can't be compensated is the location of the tear that produces the problem. And when the location of the tear is near the biceps, then it's a problem of a conflict between the biceps and the tear. This is what I think is why some partial tears are completely asymptomatic, we see them all the time, and other partial tears are symptomatic, and whatever we do conservatively, we fail. We just make the patient feel good for a while, either PRP injections, cortisone injections, physiotherapy programs. Patients feel well for a while, and as soon as he goes back to activity, he starts having problems again. And this is what...
I like the question. So for me, the partial tears, bursa-sided, are the most painful tears that you can find. So partial tears, articular-sided, totally fine. Bursa-sided and even anterior bursal-sided, those are the most painful tears you will find.
Manos,
But both could be
You
painful.
have operated this patient, right? Here, on this side.
Yes.
You operated this
I'll
patient.
show the case in a bit.
Yeah, and what was the tear? Whether it's a pasta lesion or a bursa surface
Should we see it? Is there an arthroscopic view as well?
Unfortunately, I don't have here.
Can I just comment on what Felix said, which is correct? But the bursal side are the ones that you don't have to repair. Once you remove the impingement, they will heal, because the tension is the way that they will heal. The joint side are the ones that will not heal.
If it's B2, B3 though, would you wouldn't?
If it's bursal side, once you reduce the impingement, you remove the conflicting spur, they will heal.
But this is the exception, the bursal side.
Yeah,
theory.
correct.
Yeah.
Correct.
Yeah.
So was it a bursal surface tear? Manos.
Okay. So what we do to this patient?
So let's see, actually, because we don't want to let the fists talk here. So that was an ideal cuff repair, high initial fixation strength, minimal gap formation, mechanical stability till tendon bone healing, high contact pressure, and low tension.
You have to
okay.
have
No.
Sorry.
We want a video of the tear which you have repaired, the same case. Yeah.
Is this one? No.
No. You have to go back and πηγαίνετε πίσω και βγάλτε την ομιλία που είναι για τον κύριο Κούκο, όχι αυτή που είναι για μένα. Αυτή δείχνει το τι έγινε.
Okay, there was another patient in order to actually
I think
to actually prove that he needed
I tried
the repair.
Did you do the biceps tendinosis as well?
He did.
Manos.
He did.
He did. So he did
Yeah,
a cuff
so-
as well as bicep tendinosis.
We did a suprapectoral tenodesis of the biceps, and then we did a transosseous repair of this small tear.
So
One hole, 3 sutures, and then we used the biceps as a graft, as a free graft.
So-
to,
as he said, as a referee, I'm going to say it. Yeah. It's not the right one now.
Neoplasty.
It's a medium-sized tear of supraspinatus. Was it a transmural tear? It was a.
It was somewhere healed, something like it was a small tear. Practically, it was
Okay.
a small tear. It
So-
was in the anterior part of the supraspinatus. Practically, you could say, and I could agree with Hofer, that you could just do a tenodesis of the biceps, and then
Yeah.
acromioplasty. But the fact that we had this patient in the operating theater, I was thinking that I would do anything that could increase the possibility to have a non-painful supraspinatus tendon. So we repaired it, we put grafts on it in order to augment it, and then we put PRP and stem cells and anything else that I knew.
Don't you think that's too much? Actually, just
Maybe.
using a graft on top, like for
PRP
just a
and
small
stem
tear.
cells and graft,
And
this is-
PRP, I don't have PRP.
It was too much.
The less is more in this case.
This is a problem of how you can see this. The problem is that having him there and looking at all this, trying to think how I could produce, this is 6 months after the operation.
Okay. And
Same patient?
okay.
The patient,
The same patient, yeah. So let it play. Huh. Okay, and do we have another one? No.
yes, and then we had
T1 as well. Did he have private insurance or he pay a self-payer?
He didn't have the private surgery, but all this are very low cost.
Yeah, it's his own bicep. Sorry. Yeah, you're right.
Yeah. And the next? And this is the patient, again, 6 months post-op. He has returned to full active.
Okay. He just lost his hair.
Yeah, and yes, and he abandoned some of his activities, saying that I'm too old now. But still now, he's saying something about the other shoulder.
And he's based on other activities, you know, for...
Yeah.
Okay. Well, I have the nanoscope examination.
Is he lifting weight again?
Yeah.
Already?
Yes.
Okay, there's a nice one. Don't we have like during the operation? No, video. No.
I
Okay.
would love to see the arthroscopic view before the operation. I mean, during
Yes.
the first operation.
The history and the clinical situation is that drove me to this solution. What is interesting is that you cannot see the biceps. You see just a healed calf. This is the subacromial space, from the subacromial space.
And what you did was subpectoral tenodesis, right?
Suprapectoral.
Supra. No,
Get
supra.
to the subacromial space and go low to the subacromial space.
Okay.
Go about we usually take a graft that is something like 7 centimeter graft. If you anodize the biceps.
Yeah.
To be honest, Manos, not seeing the biceps is something I would expect because I've scoped several now where I used this as a anterior bridge reconstruction.
Yeah.
And they all heal into something cuff-like tissue. It's not that you see a single strand if you use a
This
single
is very,
strand. It's completely,
the same
completely gone. It's always like
the
that.
same goes also with
Yes.
that you can see nothing.
Can't
They are
see
just,
the biceps tendon
very
anymore.
well healed tendon.
Christos,
we have a question.
I have a comment, like regarding the articular side tear, you know, it depends like whether it is a post-traumatic acute tear or it is a degenerative tear, okay? Now, what is the progression of such tear? What is the like symptomatology if you don't treat such patients, you know? They will come with a stiffness maybe after a few months to you. So what I feel, as far as the function of the supraspinatus is concerned, the deep layer or the articular side layer is very important because that is where the capsule is attached and that most of the function comes from the deep layer, okay? So whenever I found like the demanding patients and it is an articular side tear, like maybe say more than 40–50%, definitely I will try to repair it. And as we know that as there is a tear of the deep layer, usually there will be a violation of the lateral pulley of the biceps also. So the biceps become more unstable. Then in that case, we need to address the biceps also. Okay?
Okay.
So stiffness is a main problem in such young patients if you don't treat. Yes. Yeah.
Good.
Manos,
A question to Miguel. What we have seen in when we used, I used the Regen 10 in 45-old patient repairing medium-sized tears. And what we see is that in the rehabilitation period, they are advancing much quicker. The pain subsides much earlier. And practically at 2 months, we see the patients moving the arm like something 3 or 4 months for the usual repairs that we do. Have you an experience in this? I mean to all the participants. Have you an experience?
You think this is because of faster healing?
I don't know. I think that something happens and the patient gets out of the acute phase much quicker. The capsulitis that he's doing because he is moving quicker is less. And the patient...
So you don't follow the same rehabilitation protocol when you use a patch or not?
The rehabilitation program we follow is that we take the patients to the limits that pain allows. So we are not having a period that we have a response of the patient to the rehabilitation. If he is responding quickly, we are going faster. If he is responding
independently of the size of the tear.
Yeah,
so the size of the tear makes the response.
Yeah, but
I mean,
at the same time, even with transosseous repair, I haven't done it, but I was talking with Paul.
Yeah.
Well, I don't know if he's already here. They don't have pain like post-operatively. That's what he told me. That's
They
the
have
good thing
less
about
pain.
transosseous.
Do
they
you
have
use
less
PRP
pain.
as well?
Less pain. That's what I said.
They don't have pain. They
Yeah,
have
okay, they
less-
have less pain. Okay. Okay. That's
Manos,
what I
do you
mean.
use PRP as well at the same time?
Excuse me?
PRP as well at the same time? Because we noticed that with the PRP. They are much quicker and much less
We
painful.
do many times. We do BMAC now, bone marrow aspirate, and PRP at the end of the operation. It's very quick to do it, and it's very cost effective because
Much less painful, yeah.
Okay.
For the biceps, how long do you limit them to go back to weightlifting after biceps tenodesis?
Again, it's not how much we get them out of weightlifting. It's what is the amount of weight that he's lifting. So practically after 2.5 months, we get them to active use of the arm and slowly to resisted use. And we again follow the response of the patient, because I don't think that all the patients are having the same rhythm. We have some very periods that are the statistical
proper
mean.
lifting, probably 6 months, I believe.
Yeah.
No, I would be much quicker. So isolated biceps tendon, 6 weeks. And I've not seen like a increased number. It's the same number you will get if they are 6 weeks or 3 months out. It's
How many
the
of
one
them
that
you
does
have
not heal.
slipped out?
After tenodesis, you mean?
I think
How many of them you had
Miguel?
split out? And have
I got a question.
yes.
Go ahead. Go ahead.
So,
Sorry.
you know,
Healed after
very
6
quickly,
weeks, they
the
will
good
not.
thing about this trial is we were completely blinded. So we really didn't know. We were assessing the patient postoperatively, and we didn't know if they have the graft or not, because I follow up the patients my partner did, and I did follow his patient. So I did not know what type of patient we had. And we look at pain postoperatively at 1 month, and there were absolutely no differences. So between the control group and the Regeneten group. So widespread knowledge that Regeneten might reduce postoperative pain. It was not the case at 1 month follow-up in my patients. The other concern is related to stiffness, because there has been a couple of reports of increased stiffness. So we look at that very carefully. And at 3 months, there was absolutely no difference neither. And that was 64 Regeneten implanted, and none of them had a stiffness that required surgery. So I don't think, at least following the same postoperative protocol, you will get more or less the same results at 1 month and at 3 months. You won't get more stiffness. As we are on a stage that, given that we have increased healing, we will go faster, at least on my side. On my side, no, because in my control group, I have a return in 1 in 4 patients. So I'm not happy with that. I want to get my healing rate way up before going faster. So no, not faster for me with Regeneten, at least in full thickness tears. Partial thickness tears is completely different because you are doing a very different operation.
Okay.
So it's obvious that the winner is the double row repair, of course.
There's no winner. Thank you for this fair fight. So we can close up. Thanks everyone actually for the support and doing actually everything with us.
Wait for me, because I think I had an advantage from the referee. Okay, so.
Okay, yeah, now the winner all of a sudden, huh?